Good evening and welcome to today's webinar. I'm Danae Abram, the Healthcare Innovation Supervisor with Well Ahead Louisiana. Thanks so much for joining us today. As usual, your lines are muted to prevent background noise, but please feel free to enter any questions either from previous sessions or any that come up during the presentation. Please go ahead and put them in the Q&A box and we will be sure to answer those. Today is the 11th webinar in our Telehealth and Practice series presented by Dr. Ted Hudspeth. And today he's going to be doing a telemedicine literature review. The slides and the recording of the session will be available on our website along with the recordings of all the previous sessions at walpen.org/telehealth. We are also working on 4 pre-recorded sessions. The first on-demand session, Best Practices in Care and Communication, is actually available now on our webpage. And the remaining 3 sessions are in development and should be uploaded soon. As a reminder, this series is funded in part by the TxLaw Telehealth Resource Center, which is a HRSA-funded program out of Texas Tech University to provide technical assistance and resources to telehealth programs in Louisiana and Texas. And we at Well Ahead are partnered with TxLaw to serve as the support representative for Louisiana providers. And TxLaw is part of the National Consortium of Telehealth Resource Centers. And with that, I will hand off to Dr. Hudspeth.
Well, hello, everyone. I appreciate everyone's patience with us. We weren't able to be with you last week, but we are getting started again this week. We will be having another presentation next week, so it'll be kind of back to back, so join us for that one. I did want to open the floor for any questions from any of our previous sessions, if anyone has any. Danae, had anyone emailed you about any questions at all?
Nothing this week.
All right. Well, as we go along, if anyone's here on the conference, you can put that into the chat and Danae will get that to me. So I'm going to start with a quote. We are entering this era where if you don't have an outcome, you're not going to have an income. And that was from Sandra Nichols of AstraZeneca. So, you know, we are all moving towards a value-based medical economy, really. You are going to have to prove, you know, number one, what you do has some benefit for the patient over time. And, you know, there are many ways to do that from our computer systems to be able to track things, et cetera. But we have to start with a core set of values and a core set of information where we have outcomes or being able to show that what we do in our practice has some benefit or outcomes data. Okay, so telemedicine is no different. Right now we are really at a point in time where telemedicine is still so new. Man, we need so much study to be done on it. You know, it's really in its infancy. So I wanted to do a literature review to be able to kind of look at some of the things that are there now to show you where we are and at least to have some idea of things that are coming or things that people are showing benefit with. There are many things that have not shown benefit yet because probably the studies haven't been done currently. There are many people working on this. The studies on telemedicine have just skyrocketed in the last year because of COVID. And, you know, our data's getting a little clearer now, but there are still many, many things to be done. So I kind of wanted to go through this, but this first statement about if you don't have an outcome, you're not going to have an income, that spoke a lot to me because we actually in my institution where we work, we're actually partially getting paid based on our outcomes. And so everyone's pretty focused on it. So I'd encourage you to do the same because it's coming. Everyone's going to be doing this pretty soon. So going through an overview, I'm going to take you through some studies on some acute disease specific research, including some infectious disease and antibiotic stewardship, and then talking specifically about urinary tract infection care. I'm going to go through chronic disease specific research, and these are the big ones that we all deal with: hypertension, diabetes, hyperlipidemia, and asthma care, both in adult and pediatric patients. And then some other healthcare providers' impact. where other providers are actually showing some very good outcomes data in their own world with respect to how patients do when they intervene and help patients along. And I'll try and tie that into some of the payment structures that are actually coming down the road. And then healthcare delivery research. So how we deliver healthcare is changing dramatically. And there are a few things out there that are really sort of niche right now, but I think that they will be very big over time because number one, they do have some good outcome studies. They are very cost effective and patients love them. So that is going, because of the convenience. So when you pair all of that together, that's a big value to people. And most of the time when things are valuable, they're going to get utilized more. So that's just kind of the nature of the beast. So we'll start off on some of the acute disease specific research. And this concept of antibiotic stewardship. Now I've been practicing, 27 plus years now. And when I think back to how antibiotics used to be utilized versus today, there's been a big shift. I think everyone very much indiscriminately used antibiotics when I first came out in practice. It was just sometimes easier to write a prescription for an antibiotic than it was to actually have a conversation and with the patient and talk with them about why they really don't need an antibiotic. And that was not good medicine because there are problems with that, antibiotic resistance, et cetera. And so this concept of antibiotic stewardship has come about, and we are using that in our own institution, and it has dramatically changed how people utilize it. And the whole thought about this is, first of all, you educate people about, and we're talking providers, you educate providers about antibiotics, its appropriate use, inappropriate use, and then you kind of make it very transparent as to who is utilizing in a certain way. And you follow that up with, more education on for folks who are not kind of going with the standard of care, so to speak. And these types of programs have been shown to be very helpful. So in looking at antibiotic use with an antibiotic stewardship program in telemedicine, there was a study where the title was Antibiotic Stewardship in Direct-to-Consumer Telemedicine Consultations Leads to Higher Adherence and Best Practice Guidelines and Low Prescription Rates. So they basically looked at 5 diagnostic groups for which included upper respiratory infections, tonsillitis, sinusitis, UTIs, and acute diarrhea. And physicians were trained on the current guidelines of utilizing the antibiotics appropriately within their own institution. And then they analyzed the antibiotic prescription rates among for all of the patients and referral rates and the actual antibiotic classes that were utilized for all of these different things. So in this particular study, there were over 2,300 patients that were included in this, and they looked at different things like, red flags of use and that kind of thing. And they also looked at referrals for face-to-face consultation. So basically, if the provider on a telemedicine visit could not or did not feel like they could provide appropriate care, they would be referred in or would need to see them face-to-face. So among all of the discharged patients, they actually looked at the percentages of folks that got antibiotic prescriptions. And the results of that showed that in an upper respiratory infections, 2.5% got it. Tonsillitis patients got it 35% of the time. In sinusitis patients, 51%. Urinary tract infections, 91.6%. And in diarrhea, it was 1.6%. And these were actually compared to face-to-face visits, and it showed very similar rates of antibiotic usage when the antibiotic stewardship program was utilized in these patients. So it showed that telemedicine usage of antibiotics when you use a stewardship program is very similar. Why I thought this was an important article is because one of the I guess, complaints about people who use telemedicine or perform telemedicine services, the thought is that those doctors will just indiscriminately provide antibiotics no matter what the problem is. And actually utilizing an antibiotic stewardship program has been shown to reduce that risk in an institution. So that's a good thing. And then there was another study looking at antibiotic use when they just educated the providers versus giving them education and feedback afterwards. So basically they would give them the feedback. And that's kind of what I alluded to in our own institution, you know, having the transparency and the feedback of where do you stand compared to other people in your own institution. And in that study, they did show that education plus individualized feedback in a telemedicine practice significantly reduced the antibiotic prescription rates for upper respiratory infections and bronchitis compared to just using education alone. So if you're going to institute a program like that, it's best to give the feedback also, not just the education of, you know, what you should be doing to begin with. So I thought that was interesting. And I've experienced that because I've seen dramatic reductions in antibiotic usage in our own institution by using this type of thing. So then I wanted to look at urinary tract infection care, because this is actually something that we do see a fair amount of when we're doing urgent care through telemedicine. We see a lot of urinary infection type issues. And what this looked at was the comparison of diagnosis and prescribing practices between virtual visits and office visits for adults diagnosed with an uncomplicated urinary tract infection. So when they did this, they actually found that UTI care through a virtual visit was actually associated with more appropriate antibiotic usage. So in the face-to-face visits, what happened in this study was that providers went with maybe second or third line prescriptions way more than the people who were in a telemedicine visit. So, you know, in this institution, they had a stepwise list of what you should use, first line versus second line, et cetera. And the face-to-face folks went to second and third line, which was more potent antibiotics. And that's probably quinolones and things like that, instead of using maybe the first line like Bactrim, okay? So they actually showed that the virtual visits was associated with more appropriate antibiotic usage than in the face-to-face visits. So that was pretty cool for me to see that, where telemedicine came out ahead. And then there was one looking at antibiotic use for urinary tract infection, and they compared e-visits versus face-to-face versus nursing protocols. I included this study because I wanted to discuss the thought of an e-visit and what an e-visit is. An e-visit is where a patient that has portal access to you actually can go in for some simple problems, like in urinary tract infection is one. They can go through a stepwise questionnaire to put in all of their symptoms. And then that is sent electronically to the doctor. That's an asynchronous visit, okay? And it is a billable visit and is something that many physicians do now with just telephone notes. But this is very organized. You know, the patient goes through all of these stepwise through these questions in a stepwise fashion. That's presented to the doctor, and then the doctor makes an evaluation and management decision. So I wanted to include it because e-visits are something that I truly feel are going to be a bigger thing over time. I think in the next 3 to 5 years, you're going to be seeing a lot of e-visits occurring in many practices across the country. There are some that are doing them now. In this particular study, they showed that the e-visits for urinary symptoms and UTI offer patients a convenient option for care without an increased use of antimicrobials, follow-up, or adverse clinical outcomes when compared to face-to-face visits or nurse-administered phone protocols. So in this study, the nurse-administered phone protocols, they actually had the nurses utilizing, kind of going through the same decision trees, okay, that is set up, but that's not really a billable type thing. And, we've talked in many of our sessions about there are many things that providers are doing now. It's providing a service of evaluation and management, and that is how providers get paid. A lot of that has been being done for free. And what's happening is that's occurring more and more and more and consuming more and more time. So I think that's why, when push comes to shove, I think you'll be seeing more providers doing this type of thing, because it really does take a lot of resources to, when you start having more and more of that happen in your own practice. The point of these studies, though, is that you can do that safely and effectively. So moving on to some of the chronic disease specific research, and I wanted to cover some of the things that we all do a lot of in our practices. So hypertension is one of the big ones. This is one of the ones that came out the block, so to speak, whenever telemedicine started becoming more popular. And in this particular one, this study looked at the evidence and recommendations on the use of telemedicine for the management of hypertension. And this was a really big study. It was an international expert position paper. So what they wanted to look at on here was, if you're going to do this type of thing, what has been shown or proven to really make this type of a method of practicing for hypertension effective for patients. And this was basically their summary. I'll go through that. They showed that when remote monitoring and transmission of vital signs was used, so that meant, as we've discussed in some of our other presentations, the patient actually recording their blood pressure with a Bluetooth-enabled sphygmomanometer and having that send in the values into the charting system, and then following that over time. Number two was including some sort of a medication adherence program as part of all of your therapy that you're doing. So really focusing on adherence. And we've talked about, there are some apps that interface with patients to be able to have them click in when they take their medications. One of our presentations, we showed there are actually machines that do that for you now and queue up your meds and things like that. But having a focus on it and having the program actually ask patients about their adherence improves patient outcomes. Education on lifestyle and risk factors was another key thing that needed to be in a program to make it effective. Just having someone track their blood pressure in actually when they went through all of these studies, just having them track their blood pressure was not enough. And that's why they added these other things in. So education on lifestyle and risk factor modification was a very big part of this. So basically, you're putting tools into patients' hands to be able to manage themselves. And I think that's where a lot of this is going when you start talking about, putting all of the monitors and the trackers in patients' hands. You're giving them that opportunity to make themselves better, and giving them the education to do that is a critical part of it, or they won't use it appropriately. And then video consultation as an option, throwing that in, that is being able to do their visits was more of an optional thing. The other things that I'm mentioning actually were more important in their recommendations. And then the use of mixed automated feedback services with supervision of a multidisciplinary care team. So what does all that mean? The automated feedback services, that's where, for instance, if they had an app that, every time they entered a blood pressure that was high, the app would automatically tell the patient, something like, did you remember to take your medicine? Have you been watching your salt? Have you exercised today? Various things like that, to remind the patient in an automated way the things that they should be doing. But that's also paired up with a group of folks who are specialists in their fields, like a health coach or a dietitian or exercise person, to basically interface with the patient and start educating more, asking them, what did you have in your diet, and those kinds of things. So when you pair all of that together, that is what they really felt needed to be in a program to be the most successful program you could possibly have. And then looking at various indications of who do you put in this type of program, they recommended that you screen, if it's people being screened for suspected hypertension, so it's, they come in your office and it's high, you track them over some time at home in their normal habitat, trying to make sure that they truly do have hypertension or not. Management of older adults, so those folks who can't make it to the doctor's office very easily. Medically underserved folks, so those are folks who maybe are in rural areas or can't get to the doctor, again, because of, they don't have a car or things like that. High risk hypertensive patients, so these are patients who are very high or have congestive heart failure or coronary disease or other major medical problems that need to be tracked closer. And then patients with multiple diseases, that makes sense. And then people who are isolated due to pandemics like COVID, being able to track their pressures and get them to goal. So this is just a schematic of who they felt was down here, the best people to, I'm sorry, it's all of these, the best people to be able to put in this type of program. And then these are the big ticket items of things that you need in your program to be able to follow people appropriately. So then another study on hypertension, they showed improving hypertension control and patient engagement using digital tools. Now, this is actually a paper that I had presented when we went through our hypertension digital program that we talked about at one point. And I just wanted to highlight it again. This was one of the first papers that came out, and it was actually out of our own institution and utilizing our digital hypertension program. And in that program, they showed a 71%, at 90 days, 71% of digital medicine program patients versus 31% of usual care patients. That means patients that came to our offices for adjustment of medications, had achieved their target blood pressure control. So that's double what we normally do in our offices. The telemedicine program at 90 days had twice as many people controlled at 90 days. That's a big statement. That's a better program, okay? And also sodium consumption decreased from 32% to 8%. So I wanted to focus on that because we talked in that previous paper that consortium's recommendation was being able to teach people the things that they need to do. The educational piece was a big part of our digital medicine program and continues to be a big part of that. So putting that information in patients' hands dramatically changes their behaviors and it changes their outcomes. Again, we're trying to prove our outcomes and through this data. Patient activation scores were shown to increase. All the studies on patient activation has been shown that the more activated your patient is, the more they are engaged with their care, the more that they take their medicines and do the things that they should do, and their outcomes are better. In addition, it showed that the digital medicine program was feasible and associated with a statistical improvement in blood pressure control rates and lifestyle changes. And I think that lifestyle change is a big deal there. So that's our own program right now, and it shows that digital medicine works. And I also wanted to talk about the mHealth. I did bring up mHealth before in one of our presentations. mHealth is basically where you are putting apps mostly into patients' hands. And some of these apps, some of this never interfaces with a provider. It's actually the patient using the app to remind them when to take their medications or remind them to exercise or remind them to do everything you can think of. But again, it's leading to some lifestyle changes and it's putting that into patients' hands. So I wanted to kind of look at that. With this particular mHealth program, they actually showed, or they looked at outcome measures with blood pressures, medication adherence, and self-management behaviors and costs. Okay, that's a big word. They showed a greater reduction in both systolic blood pressure and diastolic blood pressure when the mHealth group, or with the mHealth group, okay? They looked at 16 different studies and they showed that those particular ones had better medication adherence and behavioral changes in those intervention groups. 8 did not show any statistical change. So there's still some variability out there in the data. There will be more data coming, I can promise you, on that particular topic, because there are lots of people who want to get into the healthcare business that aren't actual providers. People who are providing software solutions are wanting to do it too, because obviously, you know, that's what, a quarter of our GDP in America. So everyone's wanting to do this. And obviously, if they have outcome studies, you got to give them some credit here. All right. So the review actually found that the mHealth self-management interventions were effective in blood pressure control. The outcomes of this review showed improvements in self-management behavior and medicine adherence. And the most successful mHealth intervention combined the feature of tailored messages. So again, I had talked about the messages earlier. And then some interactive communication and multifaceted functions. That means doing different things, like being able to enter your blood pressure and then track it over time, seeing it with graphs and things like that. So apps that did that helped patients understand where they were and were more successful, had a better outcome. So they theorized that with an increased disease burden from hypertension globally, mHealth offers a potentially effective method for self-management and control of blood pressure over time. So expect more from the mHealth world as we go through time. Now I'll talk a little bit about diabetes effectiveness. This particular study looked at the clinical effectiveness of telemedicine in diabetes mellitus, and this was a meta-analysis of 42 randomized controlled trials. So this had a lot of patients in it. It had over 6,000 patients in this particular study, and 8 studies looked specifically at teleconsultation, while 34 used telemonitoring devices. 9 of the studies enrolled both type 1 and type 2 diabetics. 21 focused on the type 2 diabetes patients only, and 12 were only on type 1. So it was a smattering of every kind of thing you can think of between type 1 and type 2 patients. The mean reduction in A1C was significantly higher in the telemedicine groups. That's a big statement right there, okay, guys? And the type 2 diabetics were actually the ones who experienced a greater reduction than type 1s. My experience is type 1s are always a little more difficult to control. So this certainly went along with that. And they showed that the younger population did benefit more when using this method. And the telemedicine programs that actually lasted greater than 6 months produced a greater benefit to people. So again, diabetes can be effectively managed through a telemedicine program. And many of these provided educational components to it. And that's felt to be why they were probably some of the ones that were more successful of the 16 versus the 8. Now, looking at complex management, sometimes we have very complex diabetics, and this particular study looked at that. And they did prove in this particular study that telemedicine for this group, out of 100 randomized clinical trials, that it was a very effective method of being able to manage diabetes. They did state that, research in diabetes should focus next on how to increase access to care. The question is getting down to not is it effective, it's just how do you get it out to more people? And we've talked about disparities in care, and this is one area where you have a high population of diabetics in rural areas or underserved areas, and getting them this type of care is going to be the next hurdle that we really have to get through. Cost effectiveness, there was no question about, patients not having to come into an office and that type of thing. The cost effectiveness was definitely there. So this particular study was entitled Clinical and Cost Effectiveness of Telemedicine in Type 2 Diabetes. And again, this was a systematic review and meta-analysis of a lot of different studies over time. And they did show a statistically significant decrease in A1Cs of people following interventions through telemedicine compared to conventional treatment. And that's, again, going through our offices. So again, thinking about telemedicine as a big part of your practice is very important here, because we can have better outcomes. It is, as we've shown in some of our other presentations, it can be less costly for us to provide that care, not only for the providers, but also for the patients themselves. And everyone is going to be paid more on outcomes, and outcomes is going to be where it's at. And what I'm showing you here is that we have a method to do that. Next, this is where I'm going to touch a little bit on other people providing services. So this concept, and why I thought this was important, is that CMS has now stated that in the next few years, they are going to be contracting with not only providers, but entities. So right now, with CMS, they contract with physicians, so to speak, or providers of healthcare. It can be NPs or APPs in general. But they've stated they are going to do this with entities. So what is that? I'm going to cut to the chase. It's looking at kind of your big box pharmacies and things like that, that will be able to take a population and manage them. So CMS is going to be giving contracts to bigger entities like this to be able to manage a population. And instead of it being a healthcare provider like a physician or a nurse practitioner, et cetera, it will be like a CVS or Walgreens. So when you look at this, this particular study, a pharmacist-led diabetes management program. So, today, many people are paid on an episode of care. In the future, it's going to be based on a capitated management. You will get a capitated dollar, and then however you determine you need to manage your patients, you can manage your patients. Obviously, if you're kind of a big box group, if you have data that shows that it doesn't require a healthcare provider such as a physician or an APP to do that, if you can have a pharmacist to do that, why not do that? And so in this particular study, just cutting down to the bottom, they actually showed that they had, when a pharmacist delivered program was utilized, they had a significantly improved A1C values, and the overall percentage of patients meeting their goals in this veteran population was big. Okay, they did a very good job on this. And in addition, patient satisfaction scores also indicated a high level of satisfaction with the pharmacist-led CVT service. So that's a very important thing. Interfacing with the patient, caring for their needs, getting them to goal, and these are all things that we've talked about in our previous sessions. And your ability to do that is going to be very important as you move forward, and being able to do it virtually is going to be a big thing too. And I guess the other key thing is that there are other folks who are going to be doing this too, and it's going to provide some healthy competition. In this particular study, it's on diabetic retinopathy. Diabetic retinopathy management or screening for that has been really, really excellent. In this particular study, it was entitled Telemedicine-Based Digital Retinal Imaging versus Standard Ophthalmologic Evaluation for the Assessment of Diabetic Retinopathy. The bottom line is that telemedicine-based diabetic retinopathy screening costs less, like it's almost half, $49.95 versus $77.80 for in-office visits, okay? So the screening is just as good, and it's half the cost. So many rural areas utilize these now. I know some of our state systems use it. Like in our local area, the public hospital, Lally Kemp Medical Center, utilizes this heavily. And it's a great way to be able to get your patient screened for diabetic retinopathy and prevent them from going blind. So the studies on this are very strong. Now, in going through hyperlipidemia, this study looked at mapping the evidence on the effectiveness of telemedicine interventions in diabetes, dyslipidemia, hypertension, all right, the big three. And in this study, they really did not show a lot of improvement with hyperlipidemia management. I really couldn't find a lot in the literature that really showed where hyperlipidemia management was good or bad. So I really couldn't find anything that was to the positive for us to show that. I think maybe partly there's a paucity of studies right now. There's just not a lot out there. I think in the end, if it's like everything else, if we manage things over time and give some education, just like diabetes and hypertension programs have been proven to do, I think the same will hold true for hyperlipidemia, but we are not there yet in the studies. So in asthma care, asthma care has been interesting because, right now they have meter dose inhalers that can notify utilization. We actually went through some of those studies on one of our previous presentations. But in this one, they studied the effects of telemedicine on asthma control and patients' quality of life in adults. And this was a systematic review and a big meta-analysis, okay? Again, looking at multiple studies. And they had over 10,000 patients in this database that they looked at. And each of the 11 studies looked at the effects of single telemedicine and combined telemedicine visits. So that was a combination of approaches, like, looking at their use of the inhalers and all of that kind of stuff. And they showed that the combined telecase management could significantly improve asthma control when compared with the usual care, meaning in our offices, okay? Again, what they're looking at is when you do things like education, you track the usage and actually provide them with ways to track it themselves, there is a big improvement in people's outcomes. So the bottom line on this, the conclusion showed combined telemedicine involving case management and our consultations appeared to be effective interventions in controlling the asthma in adults. And it showed their quality of life scores were better also. And then in the pediatric world, this study actually went into schools. So they had a school-based telemedicine intervention that included both directly observing the therapy, that means directly observing how they use their inhalers, how they use their peak flow meters, et cetera. So directly observing and then giving them feedback on that. And in addition, they had provided preventative asthma medications, as well as a telemedicine follow-up with the child's primary care doctor. So it's kind of multifactorial. And when they did that program in the schools and other local community settings, they showed that there was a decreased burden of asthma. That means an increased patient satisfaction. So burden of asthma, that meant how many times they had to use their rescue inhaler and how many days in a particular time frame they had shortness of breath episodes and things like that. So it actually did show their improvement in outcomes and decreased ER visits, which was really a neat thing too. This section on other healthcare providers' impact, this touches again in another study on a pharmacy-led impact on using healthcare on healthcare utilization. So the title of this one was Impact of the Clinical Pharmacy Specialist in Telehealth Primary Care. So this particular study actually looked at diabetes and hypertension groups, and they had a mean absolute A1C reduction of 1.61%. That other study I had mentioned was a 2% reduction. And there was a mean systolic blood pressure reduction of 26 points. That's pretty major in this particular study. And in the ones with hyperlipidemia, they actually showed a 93% utilization of being on a lipid lowering medication. So I know for myself in my own practice, one of the hurdles I have is just educating people on why they need to be on it. And they did a fine job on that. So they showed that these particular providers of healthcare could provide a comprehensive medication management service and showed some statistical improvements in their diabetes and their hypertension outcomes. So again, this is a very big thing that I think we will see in the future. There was another study, again, looking at pharmacy services, where pharmacy services were delivered via telemedicine in the outpatient or ambulatory care setting. And this, again, was a systematic review of multiple studies that were done. This particular one had 34 studies. And most of these actually focused on chronic care management in adults, including, and it was a long list, high blood pressure, diabetes, anticoagulation management, depression, hyperlipidemia, asthma, heart failure, HIV, PTSD, CKD, strokes, and COPD, and smoking cessation. And in this particular one, they showed a lot of improvements in a lot of clinical outcomes through a pharmacist-led services. So I encourage you to look at all of these and understand maybe some of the things that they're doing that you can maybe incorporate in your own practice. It really does, again, it comes down to interfacing with the patient, its relationships, its education, putting tools into their own hands to be able to micromanage their lifestyles and understand where they are with their numbers over time. And it's the numbers that we always check for the outcomes. So see, I'm hitting on a big theme here over time with all of these studies. All right, I wanted to go a little bit through some of our healthcare delivery research. So the things, how we deliver the care to people. And I'm going to start with consultations. In this particular one, looking at emergency room usage. So it was a systematic review of telemedicine applications in the emergency room. And this really looked more at kind of rural emergency rooms and when they were able to interface with specialists in more urban areas or people who were more specialized in things that their patients may need. This was actually 340 citations, of which they took 38 results that they looked at. And 11 studies focused on telemedicine for diffuse patient populations, typically in emergency rooms, as I said, and 8 studies considered telemedicine in the context of basically minor treatment clinics, minor care clinics or urgent care clinics. And all of these were able to plug in with specialists somewhere, somehow. And the outcomes showed that the tele-emergency rooms, that when they had those kind of connections, that they had improvement in patient outcomes. And this was a very good way for to offload some of the patients who would have been sent to major medical centers that are already overburdened with too many patients. This was a way to keep patients in the local emergency rooms in the smaller communities and not have to travel as much and overburden or overtax the more central and urban areas. So that was kind of neat. And I think, Mississippi has done a huge job of making a kind of spoke and wheel idea of providing care, not only in emergency rooms, but also for offices. I understand that there are a lot of APPs who have been trained. They actually have gone to the central areas. They're trained by some of the specialists to care for certain things. And then they go out to their own community, have their own community clinics, but they have a direct link with those people in the more central urban hubs. And that's been a very successful way that they've been able to care for patients in rural areas of Mississippi. I have touched before on one of our other presentations on e-consults. This concept is such that there's an asynchronous consultation on behalf of a patient between a primary care provider and a specialist. So in this particular workflow, if a primary care provider has a problem for a patient, they're not sure what to do, they have a prearranged agreement with a specialist, and they are able to collate all of the information on this patient together, send that to that specialist who will review everything and make a recommendation on how the primary care doctor should manage it, and then sends that back to the provider. Now, sometimes this also includes a discussion between the specialist and the provider. All of these steps are actually billable steps. So that's why I believe these are going to increase over time. As we have, let me back up. I think for the rural communities, this would be huge. Patients, first of all, can't often travel to the big cities to see the specialists. The costs are very high, et cetera. Plus, it's very difficult to get appointments with specialists many times. And what this particular workflow is showing is that you have decreased costs, you have improved patient satisfaction, improvement in patients getting the care that they needed because they actually, get the recommendation, whereas in our typical method, sometimes patients won't even go because they can't or won't get there, et cetera. So I really think this e-consultation program will be a method of delivering care in the future. For this particular one and the results of this one, they showed that e-consults have increased care coordination, improved collaboration between the team, and better care transitions through strengthening of relationships between community-based PCPs and academic medical center-based specialists. And this work has resulted in cost savings to patients and a positive provider satisfaction. So the thing on the positive provider satisfaction, primary care docs enjoy keeping their patients and, being a service and not just having to turf them off to somewhere else. So that's where that's come in. And then e-visits. Again, I had mentioned this earlier in this presentation. This particular one looked at an evaluation of e-visits at an academic medical center. They wanted to look at, with limited information, on whether e-visits led to avoidance of in-person care. So again, there's not a lot of studies on e-visits. This particular one wanted to see if there was actually an effect on in-person care. And they reviewed over 8,000 charts that were e-visits in this particular institution. And they showed that 23.1% of the e-visits required follow-up of medical care within 14 days. So some did require that. But there was only 0.3% with emergency departments, okay? So again, think about your own phone note usage. How many of those phone notes that you manage patients' problem through a phone message end up in your office again? This is probably pretty consistent. So e-visits are a feasible alternative to in-person care for low complexity medical issues. I mean, that's kind of the point on it. And it just wanted to look at the effectiveness of that. And then once again, on e-visits, I wanted to look at patient demographics, like who utilizes this type of service, prescription rates, and the follow-up care is what this particular study looked at. And when they reviewed over 1,000 visits, 34% had a follow-up within 30 days, with a follow-up rate of 20% when those were advised to follow up were excluded, okay? So in conclusion on this one, most e-visits for minor acute illnesses can be completed without any further interaction with the healthcare system as compared to when you're doing it through, the typical method of just, evaluating a phone message and going from there. And then looking at the particular patient characteristics, these people tended to be folks who were presenting for sinusitis and a urinary tract infection. So that was the biggest chief complaint of all of the e-visits that were performed in this particular institution. And it tended to be younger patients who would basically interface with this. It wasn't so much for the older set who would use these. And I wanted to kind of look at technology literacy, because that's something that we all deal with. Can you just get a patient into a visit, or how do they use the app, or for God's sakes, how do you even get the app? Sometimes you're going that far to try to help a patient get the app to begin with. And in this particular study, it was entitled Technology Literacy as a Barrier to Telehealth During COVID specifically. And they found that although many older adults perceived benefits from technology, they understood you could do a lot of things with it. The common barriers included self-efficacy, cost, and privacy concerns. So that self-efficacy, I found this when we went full blown with COVID, all of a sudden, bam, we were doing all of our visits through telemedicine, and we were having to teach a lot of people how to use it all at one time. One of the concerns that I saw was that patients just had fear. They feared failure. They feared that they could not do it. So one of the things that I asked our nursing team to do was to basically coach them up and say, you can do this, and I'm going to be with you every step of the way. Okay. So giving them that comfort that you can lead them through it is a major point of them even wanting to do the visit to begin with. Okay. So that's what that self-efficacy showed in this study. And I saw it. It's a real thing. So you really have to build people up. Okay. Patients also were worried about the cost. And as I said, privacy concerns. They were worried that, this was Facebook Live or something. The prior research had shown that technology adoption can be improved through education and increasing perceived efficacy. It's just what I just talked about. You have to coach them up and tell them, you can do this, and I'll help you through it and be there with you, okay? And if patients can better navigate their web browsers and applications, they may feel empowered to message their providers through the patient portal and look up healthy recipes online. That was something else that's included in there. But basically, if you coach them up once, they can do other things with their telemedicine programs and their portals. Technology literacy, this was on homebound patients. And basically, it did show that participants who lack familiarity with technology and are hesitant about telemedicine in the home when it's limited, the participants did not feel capable of learning, and the advantages of telemedicine were unclear. Again, this is a much more challenged population, and it did show that it was difficult sometimes to do these kinds of things. But when you could get them to do it, they showed that the homebound patients placed a high value on their in-office visits. So they liked going to the doctor. There was some sort of a social benefit to getting homebound patients out and having that face-to-face communication. So this did show that there was a difficulty in getting patients who were homebound to do the telemedicine visits overall. And I wanted to quickly go through some patient satisfaction information. This particular study wanted to look at patient satisfaction with and preference for telehealth visits. And in this, they did show a very high patient satisfaction with telehealth experiences, and the convenience and the quality of the perceived quality of care were two of the biggest things that rang true with patients. The convenience, there was no question about that. They didn't have to drive to our office. But once they had a visit and got their problem cared for, then they really perceived that as being a good thing, and their satisfaction was generally very high because of that. So it's kind of like if you can get them to do it once, you can really show them the value of it. And new modalities. There's a new modality about text messaging, and this does go back to some of the mHealth stuff that I was telling you about earlier. Some of the automated features in some apps, it's in the app directly, but in some programs, it actually comes from a central thing. For instance, our digital hypertension program, if I have not entered my blood pressure in a certain amount of time, I will get a text message from the institution saying, this is a friendly reminder that you should check your blood pressure and send in your values. So the role of text messaging is getting to be a bigger thing. This was actually a big thing during COVID for us also. We actually would text message patients who had been proven to have COVID, to text message them and ask them questions about what are their symptoms? Are they more short of breath today than yesterday, et cetera? And then from that information, that was all fed into a big system that would prompt or flag the nurses who were administering the program to interface with the patient directly if things were going the wrong way. So anyway, in this particular study, the role of text messaging and telehealth messaging apps, it focused on the role of text messaging applications and discussed the technical and legal challenges and reviews the current examples of doing all of this. So it said, although the applications are promising, the potential for non-synchronic, that means, not at the same time, messaging in the formal delivery of care is still in the neonatal phase compared with its grown-up existence in day-to-day modern life. So this is very early. I have seen, however, it was a big thing for us with COVID. It was a great thing for patients. And imagine when we had all of these people turning positive, there was a need to be able to manage and sift through those who were at higher risk and get those people seen versus the people who were not at higher risk. So I have seen this work. It is going to be a bigger thing, although we are in the infancy right now in all of the studies. So in summary, just a few points here. The methods used to care for patients, it needs proof of outcome. I mean, we've established that. That's how we all practice, right? And the same is true for telemedicine. The second point, there are many medical problems cared for virtually that have similar or better outcomes than in-person visits. That's a big statement, okay? And we've shown some of those studies that are out there now. There are new workflows that allow for care in ways that we never used before. The thought about text messaging and things like that. We've never done that before. And so we're still on some of that. We've got to prove our way and why it is a good thing. In some ways, some of this allows for improved access and sometimes reduced costs. So the thought of consultations, e-consults, consultations from the emergency room to a specialist in the rural area with someone in a more urban area, providing that direct to patient care right then and there and managing them. That's exciting to be able to give patients some value there, okay? Medical professionals other than MDs and APPs can improve patient outcomes via telemedicine. The data is there and it's growing, and you can bet there are going to be more people who are going to be trying to prove that. There are many barriers to be cared for virtually that still exist, okay? Broadband internet access, access to a computer or a phone to be able to do this. Those are all barriers to care that are going to need to be overcome over time to allow all of this to work. And research is still needed in almost every facet of telemedicine care. So if any of you are in primary care and want to get hooked up with someone who's doing some research in this, man, there's a lot of it that needs to be done. And right now on the front lines is really where we need that kind of thing. So if you're interested in that, you need to think about it because you are going to potentially be the key to proving what is the future of telemedicine and the care that our patients will receive. So in closing, a quote from Albert Einstein: learning is an experience. Everything else is just information. And I'll tell you, this is my own selfish reason for wanting to do all of these presentations, is because learning is an experience. Going through all of these studies, I went through probably over 400 articles in telemedicine in preparation for this presentation. And it boiled down to these that I thought were very important for us to think about for the future. Learning is an experience, and we are in the middle of a huge learning curve right now with telemedicine, starting from our first presentation on why do you do it, and number two, how are you going to choose a telemedicine platform? So I encourage you to go back, look at all of the presentations that we have made. We actually have one more formal in-person live presentation left, which will be next Thursday. And we have 3 more asynchronous presentations that I will be posting to total 16 different presentations on how to implement telemedicine in your practice. I hope that I've been able to give each of you some pearls of knowledge through all of these and incent you as to why you should be doing this in the future. We have a long list of resources here that we've put in the back of every presentation. And of course, our contact information, you can always contact Danae at wellahead@la.gov. You can find all of our presentations at www.walpen.org/telehealth. And here's my contact information if you would like to do so. So I'll throw the floor open for questions. We're a little bit over time, but man, I blew through all of that, huh? I'm short of breath now.
Yeah, I don't see any questions in the Q&A right now, but we'll give it just another minute to see if anybody's typing any questions.
So Danae, what's your thoughts on where we are with all the studies and that kind of stuff? Because I know you do a lot of reading yourself.
Yeah, there's been a lot of studies, I think, that are starting now. And I think we'll start seeing a lot of things come out in the next year, 2, 3, 5 years, where people are going to be doing retroactive reviews of what happened during 2020 and COVID-19 and the response in telehealth to the pandemic. So I think once we have a little bit of room, some space and time, people will start going, look back at that data and start, I think we'll have a lot more data to look at.
Yes.
Because the utilization wasn't very high before 2020. And so now that everybody's using telehealth, there's a lot more data to wade through. So I think we'll start seeing some really good data coming out.
Yeah. And again, those of us on the front line, I mean, we really have a huge opportunity to move the needle on that, because I mean, we're where it's at,
All right, so not seeing any questions, we will go ahead and wrap up. So thank you so much for joining us. As a reminder, the slides and the recording will be on our website at walpen.org/telehealth. There's also a form at the bottom of that web page where you can submit any questions. Our next and final live webinar, as Dr. Hudspeth mentioned, will be next week, June 17th at 5:30, and we will cover some special considerations in telemedicine. When you exit the session, you should get a survey question in your internet browser. Please put in any future topics that you'd be interested in us covering in a future telehealth education session. And as always, please reach out to us at any time with any questions. And thank you and have a great night.
Thank you.